Hey, welcome back. Today we have a case in which we're going to evaluate a upper right hand side missing tooth number 4 and a tooth number 5 that needs to come out. So the first question I always ask in a case like this for this upper arch is, what kind of guide are we going to use, and is this going to be an analog or a digital workflow? Obviously analog will always work. The negative in the analog is we have to take a second x-ray with the bite plate, and it takes away the CEREC guide, a more economical option. So in looking at this, I see this as a digital guide. I have one tooth here, one tooth here, one tooth right here. So all three of these teeth are good for CEREC integration. So as long as I have 3 teeth, that should work. And again, for my extension, I probably need about this much data right here. So these 3 teeth should be more than enough to integrate that segment of the data. So this is a digital workflow. Now, whether we use the CEREC guide or OptiGuide will be up to the specific case. With the CEREC guide, we will have to mill 2 guides, one for site number 4 and one for site number 5. Since chairside, they're limited to 1 site each. Alternatively, we can choose to have the OptiGuide made, which will allow us to mill 2 spots on 1 surgical guide. So again, that's a personal preference. So here we already have the CEREC data brought in. My only thought on this particular case in terms of the CEREC data was that we designed this as 2 individual crowns right here. Alternatively, to avoid having to bring in 2 separate SSI files, we could have called this a bridge in the software, and we could have done a onlay crown on tooth number 5 and a pontic on tooth number 4, and that would allow us to create 1 restoration, bring them both in together as 1 SSI file. Again, not a big deal, but little things that we think about along the way. And here is our plan with our implants. So let's take a closer look. I'm going to start with tooth number 5, and my first thought here is this is pretty well planned. You know, personally, what I look at in this particular case is I see a sinus that's well filled here. What's causing that? Is that a tooth-related issue? Is that a overall sinus infection that the patient has? Generally speaking, with whatever's going on in their life, maybe seasonal allergies or something like that. You know, both sides are filled. So more than likely this patient just has a cold or something going on like that. But certainly want to have that looked at. That would affect if I were doing a sinus bump or getting into the sinus. Certainly that may affect my overall treatment plan here. And looking at this particular case, you know, I like to go ahead and mentally draw out my bone. And so that looks to be my bone level right there. Okay, so when I see that, my initial implant placement is probably a hair too deep. Not bad. I'd rather err on the side of slightly deeper than not deep enough. So that's what I look at there. My only other thought on this particular implant choice is I personally would not choose the 4.7 millimeter implant. I would have a tendency to want to choose the 4.2 millimeter implant for a couple of reasons. One, it'll give me a little bit more space between the teeth because I'm going to adjust number 4, and number 2 mainly because it's a platform switch implant. So the 4.2 has a built-in platform switch. And since I know that my bone level is right here, I'm going to go ahead and bring this implant down a hair, okay? And then I'm going to go to a slightly longer implant. I think that is going to be pretty safe there, so just like so. And then I will go ahead and bring this into my central groove area, just like so. Now the question is going to be, can we get stability? And that will all be determined and based on how well this tooth comes out. And my initial guess is going to be that by the time we scrape away the infection, there's our tooth socket with the infection scraped out right there. So we're relying essentially just on this part of the implant to gain us stability. It's really highly questionable whether or not we can get the stability from that. And in looking at this right here, by the time we get rid of our tooth and infection there as well, we're hardly getting any thread engagement. So my initial guess would be on this particular case that getting number 5 stable, immediate stability, is going to be quite difficult. That being said, the other thought I had in reviewing this case was, given the amount of infection and vertical bone loss here, this may be ideally a better case to go ahead and extract the tooth, really clean this out, do some socket preservation, maybe with some PRF, mixed with the bone, and allow this site to completely heal. And that way you can determine where the bone level is going to be for both areas as well. But if I were planning this case, this is probably what my plan would look like: a 4.2 by 10. Very questionable whether or not we're going to get stability, so I would err on the side of not doing immediate placement here. So now if we take a look at number 4, again, well done. My main critiques on this one would be, one, I'd like to go ahead and rotate that slightly into the central groove, assuming that our tooth is designed well and looks to be designed pretty well there. Number 2, I would go with a wider implant here, again a 4.2, and since we made this from a 4.7 to a 4.2, that still gives us the space between the implants, and I would certainly go to a longer implant here as well. And I again put a patient on decongestant to be a little bit careful here, probably more like there's the bone level there. I think we're safe in placing this implant right there. So again, on this particular case, I would just place both implants at the same time. I would remove tooth number 5, socket preserve that area, and then come back and place both implants at the same time. Thanks for submitting the case, and I appreciate it.